We're always looking to do new things or do things differently. And we kind of look where we are now, and we've got a conference that we host every year. We have a very well structured support from the medical device companies who are kind enough to donate some money so that we can provide education for DBS nurses throughout the UK. We run an annual programming course now. My colleagues who've on the committee started a competency document off, which was well supported by PDUK, and that's been ratified by the Royal College of Nursing and gives an excellent framework for nurses starting out in this specialty. This year, we're lucky enough to have a satellite meeting at the European Functional Neurosurgery meeting in Budapest. So this is the first time we've been asked to do this. I think overall, I would sum it up as it's really great organisation to be involved, working with different nurses, and probably the highlight actually is that networking that we've got now throughout the country. But through that network, we've then produced all of this other things that are helping nurses who do this job throughout the UK.
I think excellent is the word to use. I mean, they've been supportive of the DBSNA, but also the DBS network in general, because they support that with annual meeting as well. They've, in the time of COVID, particularly, they helped us to get the registration sorted, the hybrid method of delivering the conferences up and running. So we couldn't have done a lot of what we have achieved in that respect without them. As Russell said, they've also supported with the ratification of the competency documents, equally highlighting the role of the DBS nurse and the role of DBS in the management of people with Parkinson's disease. It's a big plus from that perspective of our joint working.
When I first started, the actual equipment was pretty straightforward. The programming was limited to a few different combinations of active and non-active contacts. And the scanning techniques and things like that weren't as advanced as they are now. And then over time, as it happens in any specialist area or any area of technology, new additions of to the devices has become standard. The MRI strengths increased, so you now have much better quality images for the targeting purposes, and the device manufacturers have also added a lot of adaptations. There's been development with brain sensing technology, so you now have leads that can record brainwave activity, and this is particularly focused on at the present time for patients with Parkinson's disease. So there's a lot of work being done around that. If you go back to when I started and you had 4 contacts that were either off, positive or negative, you now have 8 contacts on each side, left and right brain, and they're able to read brain signals and interpret whether or not the Parkinson's disease is particularly troublesome at different points of the day and things like that. So that's been a massive change. And probably thirdly, the actual hardware itself, the kit, is smaller, more comfortable, and I don't think the reliability's necessarily changed. I think it's just the actual technology advances. I think we've got a much better understanding of who DBS is useful for as well, and very strict criteria on who we implant, and this is something that's developed over time. And we work very closely with the technology companies, and this is something that the Nurse Association is very proud of as well, that we do offer them the opportunity to educate our members on any of their new technology advances.
We can improve upon the outcomes for the patients given the technology that we have, but it also, as a consequence of the technology being used to help program more specifically to that patient, depending on which technology you're using, also means that for the clinician, time spent with the patient to get the better outcomes is reduced, which is obviously helpful from a workforce point of view, but also for the patients when they're coming for their programming sessions, it's less uncomfortable.
Hopefully, getting stronger links with the European nurses, that would be something that would be really positive. Hopefully, we've got a couple of nurses coming over from Canada to the conference to speak this year, which is later in Bristol. So that's the first time we've done that as well. Bringing new people in, because you always get new ideas, and we're very much we're open to change, I think.
I think one of the things that we're noticing, it's occurring in the Parkinson's nurse world as well, is that other healthcare professionals are coming on board with the specialism of Parkinson's disease and deep brain stimulation equally. So we do have now a membership that reflects that with occupational therapists, physiotherapists, for example, involved in significantly in programming DBS, so bringing additional skills to the workforce in this field. From what I can see from the membership and the colleagues that I communicate with, as we said, we are now not just nurses in this field, but allied healthcare professionals as well. So registration obviously is important, but some people come into this role having prior experience with Parkinson's disease. Some people come in without that prior experience. It probably helps to have it, because supporting people with Parkinson's disease with the many needs that they have associated to the condition, and it's helpful to have a prior knowledge of the complex treatments they can have, but I don't think it's a necessity. And then training is sort of with your colleagues, with your peers, with the Parkinson's nurses, with the consultants, with fellow DBS colleagues, and through the association with the competencies. There are also some competencies specific to the technology from the different device manufacturers. The conferences per year, peer support by attending other centres for advice and learning, but also the device companies do offer additional learning, either in person when the new technology is coming available, or if you want clarification on certain aspects now, but also support education in a more broader form, not only at the conferences, but sometimes at satellite meetings outside of the conferences. So that's how I feel we're supported with education.
I think that's where the strength of the competency document is. It gives you a really good foundation to work towards, so that you know that you're achieving the skills that's needed to be in the specialist area. Something that we'll all bring to this particular organisation is the ability to work with other specialist areas, and I get a lot of support where I work from my colleagues who are Parkinson's nurse specialists. And actually, I sort of found a nice article when I was looking through before, and it's by a small group that was Kathy McEwen, but actually it's one of my colleagues, Annette Hand, who's a Parkinson's nurse specialist at Newcastle. And they'd done the piece on impact and value of Parkinson's nurse specialists to people with Parkinson's and their care partners. And that was a grounded theory qualitative study back in 2024, so fairly recently. And obviously this was specifically looking at Parkinson's nurse specialists, but I think there's a lot of overlap with the services we provided. And on their 6th page of that little article that they did, there was a overall theory and development, and a little sort of flow chart, which is really nice. And I quite like the way that they've laid it out. Basically just demonstrates how through support, knowledge, trust, they use consistency, continuity, expertise, networks, referrals, signposting, etc., etc. Once this is delivered, the patients with Parkinson's and their carers, they reported back the sense that they were working together, improved burden of treatment, concordance was improved, it was person-centered care, it was responsivity. So an example might be somebody with a technical problem that needs sorting out. It's specialists, so that I know what the problem is with your particular device, or I know how to try and help with this particular side effect. And that all of those combined together then improves the patient with Parkinson's health and well-being. And I thought that was a really nice way of sort of framing what specialist nurses add to a service. I think there was one quote from one of the carers, or was it something like, it was like using a walking stick, I think was the reference, or it was you don't need it all the time, but when you do need it, it's there. And I think that's what we aim to provide, and again, as a nurse association, we're reinforcing the skills needed to deliver expert care.
I think there is often, and it varies around centres, the process to support patients with Parkinson's disease and how much of that is shared with their original Parkinson's disease team, the nurse, for example, because sometimes these patients are not local to their DBS centre, so that they, benefits them to continue to have the support of their local Parkinson's disease nursing team, to continue integration with community rehab, for example, those sorts of things. So I think, we are specialist nurses, and in PD and in DBS are always, the key person to bring things together, and the key person that people contact if they have any queries. And I think the other point to make, bearing in mind Russell brought up about Annette Hand's article, is research. We do link people with research, and often link people with other people who have DBS, for example. If they're asking about how the experience has been, we can link people together. Any ideas that people have to bring to the DBSNA would be much valued by the association committee members. I think that's really important, because nobody learns without being asked, and having their horizons broadened. So I think that's really important. Very important to let people outside of the DBS network know that this is a fascinating specialism that blends not just your skills as a clinical nurse and your clinical knowledge about these conditions, but it also enables you to use some of the upcoming technologies and some of the things that are in the NHS plan, such as AI and technology to support the management of our patients. And whilst we want to see great changes in disease-modifying therapies or cures for people with Parkinson's disease, we're not there yet. So we want to continue to grow the technology and the options we have to treat these people, so that we can get the best outcomes for them. I think DBS nursing is the perfect example of that. For me, when I started out as a Parkinson's nurse back in 2004, when I first went to the Parkinson's Disease Nurse Association conference, I felt so welcomed and so part of a great specialism that I've never looked back. And I think a lot of people who join the world of looking after those with Parkinson's disease feel the same. I think that's evident if you speak to many nurses. There are a lot of nurses who've been in the specialism for a very long time, and we have the oral medications, but we have infusions now, and we have DBS, and so the specialism is endless for opportunities to not only grow as an individual in your professional life, but also to grow in the support of our patients. So my message just to everybody would be is you're listening to this and you're not a Parkinson's nurse necessarily, or a DBS nurse, then open your avenues to considering it as a specialism to work in, because it's fantastic.